Mine is more of a theoretical topic, so I'll try to explain it in easier way. So this is already discussed why NACRT, and we have a definitive proof that NACRT is going to increase pathological CR and increase the overall survival of these patients with a very significant increase in the R0. So again, compared to chemotherapy and chemoradiation is proved to be superior compared to chemotherapy alone in the neoadjuvant setting. So why, next question is, who will benefit from NACRT? So if you look at two histopathologies, squamous cell carcinoma and esophageal adenocarcinoma, there is a slight difference, particularly when it comes to T1A and T1B categories. In T1A, we don't need to give a neoadjuvant, whereas in T1B, low-grade lesions with adenocarcinomas, in low-grade adenocarcinomas, we don't have to give if node negativity is there. But if it is node positive, then we have to consider neoadjuvant therapy. Otherwise, T1B and all T stages up to TA, because T4B anyway, it's distant metastasis, so we give a definitive therapy there. And up to T1B, T4A, we give neoadjuvant chemoradiation, which is superior to chemotherapy alone in neoadjuvant setting. So why do we need to assess? So we need to assess because we want to see whether the patient will benefit from definitive surgery or if we need to consider active surveillance, or we have to see whether we have to consider additional therapies in these patients. Depending upon the response rate, we take care of these things. So what do we assess basically? We assess whether the patient is fit, because that is the first most thing we look at when we are assessing the patient for next therapy. So whether the patient is fit post chemoradiation therapy, then we have to see, based upon the imaging and all, we have to see whether how the tumor is responding to the treatment and whether it is in a resectable stage or not. Because we talk about, as you have seen previously, we have talked about overall survival and pathological complete response and all. But we don't have a investigation modality where we can definitely prove that there is a complete pathological response. So obviously the most logical sense is to go ahead with surgery. That's what we all think, and that is what most of us follow in practice also. So that is the reason why we have to know exactly how much is the tumor response and the resectability of the surgical surgical resectability as such. So what armamentarium we have, what tools we have to decide that. If we look at the tumor itself, the primary, so we have to look at something within the lumen and within the wall and the surrounding structures, and then we go out to metastasis. So the first thing we have to rule out is metastasis, because if metastasis is still there, there is no point of considering surgery or definitive treatment for these patients. So we do a PET scan. We usually combine with CCT because both are complementary in most of the settings, and when we combine CECT and PET scan, we get certain information whether there is a metastasis outside, whether they have responded, or it's a status quo, or the metastases have increased. That is the most important thing. The problem with PET-CT is the low spatial resolution, so it's very difficult to assess the locoregional tumor response to neoadjuvant chemoradiotherapy. And again, we cannot definitely rule out whether there is micrometastasis within the lymph nodes, and distinguishing it from fibrosis is very difficult. And the T-staging cannot happen in PET scan. So we combine a CT scan where we can have more information about the T-staging, particularly T3 and T4, because again, CT is not good for T1 and T2 lesions. So what do we look at CT? We look at the changes in the tumor size and extent, because when we look at the short axis and the long axis of the tumor, the decrease in short axis is more important, significant compared to the long axis. When the mural thickness is decreased, then there is a good tumor response. That's how we take it. Then we have to look at the T3 staging, perilesional fat stranding and all, then the surrounding organ involvement. So once there is an organ involvement, again, we have to consider to give whether to give a definitive chemoradiation or to go for any palliative methods. Then we look at lymph nodal assessment. Again, size reduction. CT compared to endo-ultrasound is not that good in assessing the lymph node sizes and considering other features of metastatic disease. Again, distant metastasis, we usually take a chest CT and abdomen combined, which will give us more idea about whether there are any new metastases or persistent metastases that are still existing. And we can also know whether the metastases have decreased. But again, complementing it with PET-CT, we'll have better idea whether it has spread across the body. Again, like PET-CT, the limitation is we cannot definitively differentiate the fibrosis from the tumor, and micrometastasis is not possible. Low sensitivity for lymph nodal metastasis, and T-staging limitations are there. So when there is organ involvement, particularly in T4B stages, when there is organ involvement, when it is involving aorta, anything less than 90 degrees contact between the aorta and the tumor, we all know that it's resectable, so we look at those angles. Then we look at whether there is any fat stranding between the tracheobronchial tree and the tumor, because the more if fat stranding is good, then we will be able to operate on these patients.